Hi, everybody. Welcome to the Hair Loss Show. I'm Dr. Russell Knudsen.
I'm Dr. Vikram Jayaprakash.
So, good to see you, Vikram.
Nice to see you, Russell.
Today, I thought we'd talk about something that we've been treating our women with for decades, but it's starting to become relevant to treating our men as well. Yeah. And that's a medicine called spironolactone.
Excellent. I think spironolactone is a great drug. It's, we've been using it for a long time, like you said, in female pattern hair loss. But it's emerging as a compound that we can also use and be part of the armory in terms of treating male pattern hair loss.
Indeed, and this comes back to this idea that we want to use low-dose medications that assist in the outcome, because nothing that we use is 100% effective in all of our patients. So sometimes we just need to find the right combo. Yes. So what I'm going to show our audience on the board here is a little bit of the biology of what we're talking about in male and female hair loss, because recent evidence has shown how much of female pattern hair loss comes from the intra-hair follicle conversion of testosterone, T, across to dihydrotestosterone, DHT. So there's an enzyme that does that. And so we've been treating the enzyme now for the last 25 years with finasteride, and more recently with dutasteride, to block some of the enzyme activity, right? So if we're using finasteride and dutasteride, that's what we're trying to do, to reduce the amount of enzyme activity and reduce the amount of DHT being produced inside the follicle. But the interesting thing is that both testosterone and DHT, when they're inside the follicle, are only active if they bind to a receptor. And the AR here stands for androgen receptor, androgen meaning male hormone receptor. So for testosterone and DHT to exert an effect upon the hair follicle, it has to bind to the receptor. And the unfortunate thing is that the androgen receptor in our hair follicles prefers 100 of DHT to every 1 of T. Yeah. So this is the one that does the damage. So that's pretty unfortunate. So what we've done in the past with women is we've used the medicine spironolactone because it's an androgen receptor blocker. And so it interferes with the binding of DHT and T with the receptor. Now, we haven't tended to use it in men in the past because we feared that if we put too much of this medicine in and block too much of the receptor, we'd be blocking testosterone binding to the receptor. And if you're taking it orally, it's testosterone everywhere, not just testosterone in your scalp. And we had this fear that we were going to do a feminization of some of our male patients.
Because one of the side effects of using spironolactone is things like gynecomastia as well.
The enlargement of breast tissue.
Yes. And that's at much higher doses.
Right? So what we've learnt in years is that we didn't need to use as much as we thought we did to get the effect. So the dose in women that we're using in Spiro has come down from what was 200 milligrams down to 100 milligrams, but most people now use 50 or 25 and just milligrams. And just recently, in the last few years, we started to see people showing us results in the literature by using 25 milligrams of spironolactone in our men. So it's enough to give you some receptor blocking to reduce the amount of DHT that's remaining binding, but not enough to cause feminization.
So I think the strategy here is not to get a sledgehammer, right, and whack the different things with a sort of a big sledgehammer, but actually target little bits of every part of the pathway.
So this is the evolution, because what we used to do is just work on the androgen receptor with women and just work on the enzyme with men. But now we've started to use enzyme blocking in women because we understand that there is the enzyme is involved in the process. So we're starting to block the enzyme in women, and we're now starting to block the receptor in men. So there's a convergence, if you like, of the way that we're treating both male and female patients by understanding that multi-level treatment in this area here is likely to be superior than single-level treatment.
And we know that, say, finasteride, for example, reduce the DHT by about 2/3, right? So that has part of the effect. And so what we're doing is adding the other aspect of things by trying to block that androgen receptor side of things, and that's by using that low dose of spironolactone. Not very much, just 25 milligrams.
And it's not a new medicine. It's been around for decades, so we know exactly what that medicine does. And in low dose, it's very safe.
Yeah. And I think it's also been used in combination with minoxidil as well.
Correct.
Because one of the issues with oral minoxidil is the water retention associated with that. So having that as well to combat that.
To explain to the audience, it came on as a mild diuretic, meaning that it's designed to help get fluid out of the body, to evacuate excess fluid. So it's kind of a counterbalance, if you like, to the potential side effect of minoxidil as well. So it has a dual purpose in this circumstance where you're blocking the receptor, but also make sure that you don't get fluid retention.
So I think, that's a useful additive, right? It's certainly not first-line treatment. Again, we've talked about in the past, first-line treatment probably looking at...
I like a blocker, which is finasteride usually, and a stimulator, which is minoxidil. That's usually my go-to starting point. Then we assess, and if we're happy with the result, I don't change it. But if we start to see some, progression of the hair loss, for example, and not getting what we want, then we can start to tinker at the edges. And this is one of the ways we tinker. Is we can do a bit of receptor blockade. We can actually supplement the finasteride with a bit of dutasteride, which is about 50% stronger. But not to overdo it. The idea being we want to get the effect without the side effect.
But still sticking to the fundamental principle, which is what is the smallest dose of the least number of medications that I need to give this patient to maintain stability.
Correct.
So it's not about throwing the kitchen sink when someone comes in and throwing the kitchen sink at the problem by going, right, we're going to treat you with finasteride, dutasteride, minoxidil, and spironolactone all in.
Well, this is when patients say, what else can I do? And I'm going, if you keep doing other things, then ask me what's working and what isn't working. I'm not going to be able to answer your question because you've put too many things into the mix. So let's start with the things we know work, which is, enzyme blocking we know works. It's the single most important thing we've done in the last 40 years in hair loss. And then add some stimulation in. And then if we have to do a bit of receptor blocking because we haven't quite got what we want, then so be it.
Perfect. All right. Well, I hope you found that useful and in that discussion about spironolactone. Thank you again for watching, and we look forward to seeing you on the next episode.
And keep subscribing and liking. Thank you very much, everyone.